Good morning. My name is Gillian Mackay-Smith, and I'm an Associate Director in Human Resources here at the Broad and a member of the Belonging at Broad Steering Committee. I'm very proud today to introduce Dr. Daniel Chonde. Dan is a radiology resident at Massachusetts General Hospital and is the executive director of The People's Heart, which is a healthcare community-based collaboration aimed at reimagining clinical spaces through art and design to address issues of health equity. Dan's talk today is entitled Accepting Responsibility, the History of Health Inequity, Medical Discrimination, and the Changing Face of Medicine. Just some housekeeping items. Closed captioning is available. To access that, just click on the Captions tab on the right side panel. The entire session will be recorded. If you'd like to ask a question, please go ahead and drop it in the Q&A section on the right side of the panel. And take it away, Dan.
Hi, everybody. My name's Dan. I'm a radiology resident, which is like I'm a doctor, but a junior doctor at the Mass General Hospital. And I have some slides. We'll just whoosh. There we go. So this is my talk for you all, Accepting Responsibility, the History of Health Inequity, Medical Discrimination, and the Changing Face of Medicine. Let's see if I can move. Perfect. Every good talk begins with disclosures. I am receiving a financial compensation for this talk. I don't think that necessarily makes me any less qualified to give that talk. Also, all the money that I get from doing diversity talks always goes back into our diversity programming for the People's Heart. So don't worry. Additionally, I have a number of diversity, equity, and inclusion positions. All of these positions are unpaid positions. And I mean, at worst, it makes me want more diversity in the world. So I don't necessarily think that's a conflict of interest. So we're going to go on an exciting journey today about the history of medical discrimination. First, we're going to start with some acknowledgments, then we'll move through the basics so you understand some of the topics and issues we talk about. And then we're going to discuss health inequities and emerging solutions through a number of examples. I love to talk about specific cases and use allegories and stories to explain challenging concepts. So that's the way I like to do things. Finally, we'll talk about what you can do as a viewer. And, if you've made it this far and you've decided to come to this lecture or you're watching a recording, this can be the first step into stepping into the space of equity, which congratulations, thank you, and welcome to the battle. So Reggie Gibson, he's this guy. He's a poet, he's an entertainer, he's a philosopher, and he says this, I think our problem as Americans is that we hate history. We love nostalgia. We don't want to remember things the way that they actually happened. History is messy. History is hard. History is usually a lot less rosy than we remember it as, and we hate that. Right? So the stuff we talk about in diversity spaces or DEI spaces or inclusion or equity, right? It's challenging. There's a legacy of white supremacy. There's a legacy of a patriarchy. There's a legacy of violence and crime and just all in all being kind of terrible human beings. But we always have the opportunity to define the path we go forward on. And that is essentially what I hope that you take from this. Now, this amazing philosopher and historian, Hassan Jeffries, he talks about this thing called hard history. Slavery is hard history. It's hard to comprehend the inhumanity that defined it. It's hard to, comprehend that there was this violence that was directed towards women and children and, breaking families apart and murder, and the fact that it was justified by people that we look back on and see as our heroes, right? The whole crew of the Hamilton musical, in truth, they were all pretty terrible people because they owned slaves, right? And why do I say they're terrible people? Well, you say, oh, weren't they good masters? There's no such thing as a good master. If you own another human being, that's bad, right? And as we are able to look back in time, it's okay to judge these people. Just the end of that. So, basics. Introductory to health equity. Now, there are many terms for this thing. Some people say D&I, diversity and inclusion. Some people say EDI. Some people say IDEA or DEIB or I dare. Right? All of these things are JEDI. People just try to make fun acronyms and move things around. I personally use DEI just because that's what I'm most familiar with. But, my feeling is whatever acronym you want, it's perfectly fine as long as you do something with it, right? You should always be using your group, using your influence, using your power to dismantle structural inequity. And if you're not doing that, I don't really care what your acronym is. It's bunk. So, who is DEI for, right? I hear it all the time here in the hospital. White men will say, it's not for me, right? No, it is. It's for everyone. There's this concept of intersectionality. This is an identity wheel over here. The things on the inside of the identity wheel are things that people most readily identify about you. And the things on the outside are things that, you usually have to tell them about or give up or, they'll find out eventually. But what this serves to illustrate is this concept of intersectionality, right? Intersectionality was coined by this philosopher, Kimberly Crenshaw, in the 70s. This was part of her work where she was talking about the joint civil rights or Black rights movement and feminist movement, and the fact that both of these movements were failing Black women because to the feminist movement, Black women was a Black issue. And to the Black movement, Black women was a feminism issue, right? So when you create these individual groups, you always have to be cognizant of what are the gaps, what are the blind spots, who's getting left out. And what intersectionality says, if we want to be successful in this equity space, we need to be able to hold all of these conversations at once. And that doesn't mean that everything has to be for everyone at every moment. It just means that people need to be cognizant of what these different groups are and understand sometimes they could be failing some groups and they'll have to alter course. And so here I say it's about recognizing marginalized groups and working to empower them, right? That's why you can have white women or Black men or transgender indigenous people running these organizations, as long as they have the ability to understand that there are going to be gaps in their personal experience and look to others to fill those gaps. So I am a doctor. I deal with medicine. There are PhD doctors who deal with public health. There's a difference between medicine and public health. The goal of public health is to prevent disease. The goal of medicine is to treat disease. I treat the person in front of me. Public health looks forward and tries to deal with whole populations. Their tools are policies, laws, the government departments. Our tools are medicines, devices, and hospitals. There's this allegory of these three women. The three women are walking down by the water, and they see these babies floating in the water. And the first woman says, "Oh my God, babies in the water." She dives in, and she starts rescuing babies. The second woman says, "Well, what we need to do is we need to teach these babies how to swim." Because they look far as the eye can see. There's a whole bunch of babies floating down the river. I got to teach these babies how to swim so they can swim for themselves because they're in the water. And the third woman just keeps on walking. And the first two, look and say, "Whoa, what are you doing?" And she says, "I'm going to go see who's throwing babies in the water and tell them to stop." Right? So that's public health, right? It's not necessarily the projects aren't necessarily a today fix. They're a fix of the systemic issues, which can be a tomorrow fix. But, the implementation of these things are important because we can look back in time right? That's the role of public health as well, is to look back in time and see these trends and try to address them. Now, concept social determinants of health. This is to say that you as an individual, your health is so much more than, just you catching a cold. So it starts with who you are. What's your age? What's your anatomy? What's your genetics, right? This is the you as a person. What is your susceptibility to an illness in general? Now, one step above that is what you do. It's physical activity, it's diet, it's occupation. If I had 3 clones of myself and one of my clones smoked cigarettes, that would negatively influence their health. If one person drank all the time, that would negatively influence their health. If one of them exercised at all, that would positively benefit their health, right? Now, above that is the conditions in which you were born, grow, live, work, and age. I was born in Michigan, a small town where I was essentially one of the only Black people there, but that gave me the benefit of being relatively left alone. So I could go grow up, become a doctor, and I don't know, do whatever it is that I do with my time. Now, if I grew up in sub-Saharan Africa, my life would be very different. I wouldn't have exposure to these opportunities. I might be working at a younger age. I might get malaria from mosquitoes. There might be war and famine. All of these things come together and affect my outcome. Now, there's many frameworks in which to view this through. This is the World Health Organization's framework. Now, I was thinking like, oh man, I'm going to draw this thing out and like do all sorts of like little PowerPoint, little shapes for it. And then I was like, actually, there is a YouTube video. The YouTube video is here. It's from Let's Learn Public Health. It's already a great slide, right? It's already a great image. Like, what am I going to do? So props to them. But what it shows you is there's these structural determinants, which are things out of your control. And then there's the intermediate determinants, also things that are out of your control, and they kind of lead to health. So there's this concept of, what are your resources, be it psychosocial resources or financial resources. All of that goes into health. Obviously, if you've ever been sick or anyone you know has been very sick, then you know that bills pile up. You know that your insurance can make or break you when you're sick. You hear it all the time in the news. So income versus life expectancy, right? This is this concept of social determinants of health, right? Because maybe you saw everything I presented and you're like, yeah, okay, but it's not real. This is an interesting study. It was in JAMA, Journal of the American Medical Association in 2016. This research team got a hold of like almost 2 billion de-identified tax records. They went through all of these tax records and they were able to trace out individuals over time, and they were able to place them in different quartiles. This is from all across the United States. So they could create a pile of people saying, oh, these are the rich people, these are the less rich people. And they could look at their age over time, and then when they stopped reporting taxes, that meant they died. And they could figure out what is the life expectancy for rich versus poor. And they could do it in such a way where they could say, let's control for being black, or let's control for being a woman, right? So they were able to essentially match people with other people of similar situations and able to come up with just kind of this normative model, which here, of course, shows the 95th income percentile, which you see here as the triangles. By age 76, many more of them are alive than the 5th income percentile. So the 95th is somewhere around like, now this of course changes from location to location, but I think it roughly works out to individuals making over $245,000 a year for the 95th, And then the 5th percentile are individuals making less than $14,000 a year. Another example is breast cancer mortality in Black women in Chicago. This is a study that just came out 2021. It came out in, I want to say, like May, right? Rush Hospital, good hospital in Chicago, looked at 20 years of their breast cancer program data. So that's 8,000 women that came through. They found the Black women had a 42% higher mortality. So Black women who had an equivalent breast cancer to a white woman, they were much more likely to die. They were 1.5 times more likely to present with metastatic disease. That means they have disease beyond the breast, but throughout their body. And they were 2.5 times, or 2 times more likely to have something called triple negative breast cancer. Triple negative breast cancer is a very aggressive form of breast cancer. And the risks of it are having more pregnancies and decreased rates of breastfeeding. Now, both of these are more prevalent in the Black populations of Chicago. So it's easy to see how these social determinants, right, like not being able to have a breast pump room in your work, so you can't breastfeed your child, so you go to formula early, or being in a situation where you don't have access to appropriate family planning services, right? So these things then tumble into increased cancer risk. So this is kind of all examples of the social determinants of health. Now, you probably have seen this equality versus equity thing. You know, the idea being that everyone wants to watch the game, but the little tiny kid in purple, one box is not enough. Meanwhile, the dad is much taller and doesn't even need a box, right? So they kind of separate it this way. Now, I'm personally not a huge fan of this. I like to think of it as bicycles, right? Everyone loves a bicycle. So equality is everyone gets the same bike. And we have a woman in a wheelchair, we have a tall guy, we have a woman who is just right, and then we have like a little kid who can barely ride. And what equity is understanding that everyone needs a different bicycle, right? It's not that we're saying some people don't get things, because everyone gets something in healthcare. But some people need a little more attention, and some people can get by with the base level of attention because they are capable of coming in to receive services themselves. They don't need that extra push, or they don't need that extra checkup, because they're capable of handling it themselves. Now, health inequity, big topic. I'm just going to go through a couple examples. My goal is to teach you how to understand these concepts through a framework. The idea being, when you're out in the world or you hear something in the news, you can say, I understand that, and I can take it one step further. Now, Hollywood will do a much better job than me. The Tuskegee syphilis study and the HeLa cells. Tuskegee syphilis study was where the government let a bunch of African-American men essentially contract syphilis and pretended to treat them. It is a huge source of medical hesitancy for the Black community. Miss Evers Boys, it has Lawrence Fishburne in it. That's awesome. You should watch it. Seriously, The Immortal Life of Henrietta Lacks. How can I do better than Oprah? I can't teach you anything better than Oprah can. Now, granted, yes, of course, these are embellishments in certain aspects, but the gist of the story is there, and that's really what it's about. These things are designed to build empathy around specific topics. And if you can develop that empathy, then you can go into the world and be motivated to help change these things, or redress these things, or to make the more ethical situation in a similar space if it ever happens to come to you. All right, first topic, American Indian diet, food deserts, diabetes. Now, you notice I said American Indian. So because it's confusing for a lot of people, here's the terminology. American Indian are indigenous people of the United States that share similar cultures, cultural practices, and origin. Some Alaskan natives, especially the Alaskan natives in the south of Alaska, are considered American Indians because they grew out of some of the first indigenous people in that area, and they share cultural practices. Other Alaskan natives, i.e. Eskimos, share similar cultures and practices with the Arctic populations. So that would include Siberia, Greenland, places north. Greenland is the icy one, yeah. So you have your Native Americans, your Alaskan natives. Some Alaskan natives are American Indians, but not all Alaskan natives are American Indians. Now you have your Native Americans, which is one space out. Those are any peoples that are in America, any of the indigenous peoples in America, which includes all Alaskan natives because Alaska is part of the North American landmass. One step out from that is this concept of indigenous. Theories, however you choose to believe it or not, everyone kind of came out of Eastern Africa, and from that first birth of people kind, spread out all across the world. The original people to settle in an area were termed the indigenous people of that area. So the Native Americans had come over, however it was that they came over, and they populated here. So we call them the indigenous people of North America. Now, that being said, I love this GIF, by the way, though it shows something that is, very disturbing. This is the land of the American Indian over time. Now, the first step is expropriation. This is the Indian Removal Act under Andrew Jackson. Essentially legalized taking lands of Native Americans. So read that as Trail of Tears, right? Displacing all of these people maybe thousands of miles away from where they have historically lived, putting them in radically different climates with radically different foods, and expecting them to live in radically different ways than they lived previously. So before, the diets of the American Indians consisted of whole foods, whole grains, fruits, vegetables, meats, whole meats, right? But as they moved, we didn't necessarily move them onto the most fertile lands. We didn't move them onto the lands that were full of animals. We moved them into essentially the places that we didn't want to live, we as American society. So then the question is, well, now that we have taken them in our charge, how do we make sure that they eat? So here comes the USDA with their Food Distribution Program on Indian Reservations, FDPIR, also known as the Commodities Food Program. What we did was we gave them mass-produced, very unhealthy food, right? So the food that we were handing to them were things like bleached flour, refined sugars, lard, things that kept for a long time, things that were overly processed, canned meats. This is actually a bottle of corn syrup, which it says on the thing, if you zoom in, that you can put this in your baby formula, right? Safe to use in your baby's formula. Now we know high fructose corn syrup, man, that is a toxin that will kill you, right? It has terrible health effects. But this is the diet that we were forcing on American Indians. Now, ever the resourceful people, right? They survived. They found ways to use this food. So they created things like this concept of fry bread. This is a book came out, I think, in 2020 from this author who uses it to examine, this kind of hard history of survival, also how it connects the American Indian people, but most importantly, we look at this and we say, these foods are not healthy, and these foods lead to health issues. Now, on top of that, there's food deserts. This is the Navajo Nation. The Navajo Nation is 27,000 square miles. That is twice the size of Massachusetts. There are only 11 grocery stores in that space. Now, these aren't necessarily grocery stores like Costco or Giant, Whole Foods. These are like gas station grocery stores in some cases, right? Now, imagine having to get to a grocery store that's 80 miles away when you don't have the means to get there. It's impossible, right? If you don't have a car, if you don't have the money, if you can't take the time off of work, that's a health death sentence. So you see, American Indians families are 400% more likely to report not having enough to eat, right? 35% of American Indian children are affected by impoverishment. They have double the prevalence of diabetes. And not only that, because of limited healthcare resources in these communities, they're 6 times more likely to die from diabetes as compared to white people. So this is how health disparities develop. Now, urban heat islands in the Black community. If you haven't seen this video by Crystal Smith, it is hilarious. She's in New York and it is hot. So where does this all start? It all starts in 1930. The Great Depression's in full effect. FDR is president. If you know the Great Depression, here is Migrant Mother by Dorothea Lange. Interesting tidbit here. I kid you not, this woman in this picture is 32 years old. That is some hard living. I lived hard during graduate school, and I do not look that old yet, thank God. Now, FDR's president, New Deal's in effect. He wants to give America economic relief. The Great Depression being where essentially everyone's poor. Everyone's poor. 99% of people are super poor. So in order to kind of get things back on track, he starts this National Housing Act of 1934. This is the thing that created affordable mortgages, fixed interest rate loans, right? So he also creates the Federal Works Program, or the WPA. Now, that gives a lot of people jobs. A lot of people meaning a lot of white people. So you have a housing system which starts to build segregated neighborhoods, separate housing developments for whites and blacks. And then you have a lot of white people with jobs. So they start to build the suburbs and they start to build the hood or projects, right? Now, how do they figure out who's a good for a loan and who's not? Well, they develop the Home Owners Loan Corporation, and they're tasked with making sure people don't default on their loans. You probably know where this is going, right? So one of the first things they start to do is they look at maps of cities and they have to carve up where the good people are, where the bad people are, right? Where are the people who are going to pay them back, where are the people who aren't going to pay them back. That's time consuming, but the easiest way to do that is to just do it by large groups. So they find the businessmen, right? The 1% that still remain wealthy. They're the best bet, right? Give them the green. Now they find where your white collar workers are, still good, right? They outline those neighborhoods in blue. And then the more blue collar folks, yellow. And all the immigrants in black, we get red. Now, there is no evidence that red line neighborhoods defaulted more. This was entirely perception. However, in creating this system, it systematically prevented Black Americans from getting loans and immigrants from getting loans, which trapped them in a cycle of poverty. How did that work? Well, as everyone starts to get these up, all the white people start to get these monies, they can leave the neighborhoods, right? And they start to abandon their properties because they're in these red line neighborhoods where they can't get any wealth, right? So a landlord who owned a property in a red line neighborhood, he can't get a loan to fix it up, so he just gives up on it. As that happens, city services become unreliable because the people who have to work those city services, one, are, if they're white, they're moving out, but if they're black, they're living in, dilapidated buildings, which make it hard for them to make it to their job in a timely and frequent manner. And then as a result of city services going down, property values drop. Well, when property values continue to drop, then whites in these neighborhoods and whites owning these properties start to flee. And then more properties get abandoned, and then more city services become unreliable, and more property values drop, and then more white people leave, right? So it's this ever shifting cycle. Now, here's Atlanta, right? Because I'm talking about heat islands. Remember that. So we just talked about redlining. Now let's talk about heat islands. Now, on the right, the little colored map, that's our redlined neighborhoods. On the left is an actual heat map, a heat image of like the temperature in parts of Atlanta. And what you see is there's a higher heat index in these areas. Now, why is there a higher heat index? Well, the way that we cool areas are essentially trees. Trees create shade. They act as a canopy blocking sunlight. Similarly, grassy areas can absorb that heat, do something with it. But what can't absorb heat really well? Concrete, cement. So these projects, these high throughput streets, these places that lack any green space, they absorb that heat and then they trap it and radiate it right back out. So these areas that don't have the nice greenery, the nice yards, they start to become incredibly hot over time. And as temperatures continue to rise because of global warming, they continue to get hotter and hotter and hotter. Now, of course, you might say, well, heat, that's not a health issue. Well, 1,500 people die per year from heat-related problems. And it's responsible for 65,000 emergency room visits. Now, outside of that, right, you have issues like heat stroke, dehydration. If you ask my wife, she will tell you that if it ever gets above 75, I cannot move. All I can do is lay in bed and hope that night comes soon and it cools off. I am totally unproductive in the heat. And for kids, it means decreased learning. And decreased learning then leads to decreased job opportunities in the future. Right? Now, like I said before, this is only expected to increase because of global warming, right? And it's magnified because what ends up happening is when it's hot in some area, the financially affluent people, what do? You buy an air conditioner, right? And you crank that air conditioner up. What does that air conditioner do in some cases? Spews out all sorts of things that only make it hotter. And it's the people who then can't afford the air conditioners who have to deal with the heat at baseline, plus the heat from the air conditioned toxins, plus the air pollution. Now, there was a study, actually. This is an interesting study, pair of studies in 2020, 2021. What the 2021 study, or what the 2020 study did, was it looked at historically redlined neighborhoods, right? Because we have all these maps because it was totally legal, right? It wasn't something anyone was hiding. So they were able to go back and they showed that redline neighborhoods were warmer than non-redline neighborhoods in 94% of cities, on an average of 2.6 degrees centigrade with a maximum of 7 degrees centigrade. Right now, if I had to deal with heat growing up, keep in mind I lived in Michigan, so it was very infrequent that it got hot. I would not be a doctor because I cannot function in heat. Now, People of color, much more likely to live in heat islands. Interestingly enough, lower socioeconomic people also likely to live in heat islands. What's the difference? Well, blacks in these regions only make up 10% of those living below the poverty line, which means you have blacks of much higher levels of socioeconomic status, which are living in these heat spaces with white populations that are of significantly lower socioeconomic status. So you have to, as a black person, you have to be even more wealthy to be able to jump the gap into a space which has normal temperatures. Now, of course, we're not going to get into topics like sundown towns. If you're interested, just Google Groton, Massachusetts, and sundown town. I'm sure you'll find all of the fun that nightmare was. Now, it's all abstract, right? We got it. Heat. It's probably Atlanta. It's probably whatever. Well, here's an opportunity for something right in our own backyard. You probably have heard of Melina Cass Boulevard in Roxbury. But you probably didn't hear about Melina Cass Boulevard for this reason. You probably heard it by the term mass and Cass, talking about the drug problem and the homelessness problem, and mass and Cass and wanting to relocate people. But Melina Cass Boulevard runs through Roxbury. Roxbury is one of Boston's heat islands. And what they wanted to do was they wanted to knock out all of these mature trees so they could create bicycle lanes so people could bicycle to work. Why is this a problem? Well, when you knock out the urban canopy, it's only going to get hotter there. As it gets hotter there, you're going to increase both heat-related injury as well as conditions exacerbated by heat, which include asthma, which include heat stroke, which include falls in the elderly. So it behooves us to save the Melina trees. Now, of course, acting Mayor Kim Janey put a stop to this, but that's only a matter of time before they try to do it again. So when you think about what you can do as an individual person, is you can actually call your local representative. You can actually go to these protests. You can actually speak out in the real world off of Instagram or Twitter or Facebook, and you can make your voice heard and protect these communities. Now, racism and artificial intelligence. This is an interesting one. Obviously, artificial intelligence, as many of you know, as being the big brains that you are, know that it requires training sets. It requires test data. You take your computer program and you hand it some data and you say, let's do a simple example with a cat or a dog. You hand it one picture and it says, I think this is a cat. And you say, nope, that is a dog. And then, or let's say cat or not a cat, right? You hand it a picture and it says, I think this is a cat. And you say, nope, not a cat. You hand it another picture and says, I don't think this is a cat. And you say, nope, that's a cat. If you do this enough times, what happens is you start to hand the computer or the program an image, and then it guesses right. Right. And then it guesses right more and more and more. And it's learning or refining its algorithm, the way in which it determines things over time, until it's something that looks like it's perfect or near perfect. Now, this is an example of when that can go awry. Breast cancer risk, right? We talked about how Black women were at increased risk for types of breast cancer, and they appeared later for some breast cancers because of either inability to access healthcare, because maybe they can't leave work, and maybe the breast clinic that they would go to isn't open on weekends or late nights, or maybe they are hesitant because their experience with a medical system which may not treat them equally, or may not believe their pain, or may not reach out to them. they show up later with more progressive disease. So we have this breast cancer risk assessment tool, which you put in some patient characteristics, and it tells you what is the risk of developing breast cancer in the next 5 years. And this is some invasive ductal breast IDC, invasive ductal carcinoma. This is like breast cancer that needs to get cut out. Now, how do you develop the program? Like we said with the cat, not a cat thing, you get a bunch of women, you look at their characteristics, you follow them over time, and you see who develops IDC and who doesn't. Now, what you would want to do is you'd want to have a group which is equivalent to the population that you're going to use it on later, right? So if you're going to use it on everyone in America, you want something that is diverse as everyone in America. But at the same time, the people putting on these projects, these research programs, are usually in very affluent spaces. So they're usually seeing very homogeneous populations. And what you have here is you have a majority white women who are used to train this model for breast cancer. So what does it do? Well, of course, in the paper, they say like it was trained, and then there's kind of like a wink and a nudge. Everyone understands it's for white women. But the primary care physicians don't think about that, right? Because they are busy, and so they want to use it on everyone. So they start to use it on everyone. And then someone comes out and shows that it underestimates the risk of breast cancer in Black women. And so then they say, okay, well, we got to fix this. So they come up with a new model, which is updated for Black women. And then, Lucille Adams Campbell here is a statistician, and she shows that this model actually performs worse than the original model, insofar as it completely gives the opposite result of what the truth is. So you have this system which is telling white women, or essentially white women, the truth, and other populations completely incorrect information. And then you try to update this model for it has to be updated for Asian Americans, or actually it's each individual group. So you have one for like Chinese Americans, one for Indians, one for, and by Indians, I mean people from India. And then you have to have the population numbers to actually try to train the data set. So groups that have less access or less income to actually develop research programs, like American Indians, they don't even have the steps to begin to train a model, even though it might be worse than the original. Similarly, this is another more contemporary result. The Gale model was around for maybe the 80s, but this is today, right? Everyone's all about AI, deep learning, and these things are complete black boxes. So these artificial intelligence tool, this was one example where the tool was used to dole out extended services for patients. So if you were a medically complex patient, so you were sick and it required like a lot of careful prodding, what they would do is that, maybe they'd sign you up for a visiting nurse assistant who would come by and see you, or maybe they'd sign you up for more frequent routine checkups. And the insurance company used an algorithm to determine this. Now some researchers found that Black patients were assigned lower risk scores than equally sick white people. Now, this all was in the data, right? Everyone thought they were doing the right thing, but they missed this larger picture of health equity and how it actually played into this. So the training data was based on the total healthcare cost in 1 year. So it would estimate if you looked like a person in their training data set who was going to cost more in a year, then they would sign you up for this program. That expects that you are going to go to the doctor when you need to go, which is not necessarily the case for all people, right? Me, I tell myself that I don't go to the doctor that often because I am a doctor, which makes a terrible patient. But let's say my wife, right? My kid gets a runny nose. My wife wants to take him to the pediatrician, right? So that's healthcare dollars that get spent. So the more he goes to the pediatrician for runny noses, the more he looks like he's someone who needs to get care. And he gets signed up for this program. Now, let's say compare him to me. I just never want to go to the doctor. My foot could be falling off, and I'll find an excuse not to go to the doctor. When I finally do go to the doctor, I'm much sicker before I start to spend even one healthcare dollar. So what that turns out to make it makes it look like Black people have to be significantly sicker in order before they need treatment, but it's not necessarily a need issue, right? Because I could have been treated much earlier, but I was hesitant. And this plays across many other populations as well, especially our Latin and Hispanic communities, patients with limited English proficiency, indigent populations, so those individuals experiencing homelessness, right? Much less frequent to come to care because of systemic barriers, which then put them as lower severity illness. And so here's a little number from that study. So 17% of Black people were assigned this advanced care when actually 47% qualified for it. And it was all the bias of the model. Now, making amends. First step is saying you're sorry, right? Understanding even if it's not something that you individually did, we've all been part of a system which has systematically oppressed people, and we have to fix that. We call that reparations. Now, don't ask, don't tell. So don't ask, don't tell, 1994, don't ask, don't tell is put into place. For those of you who are unfamiliar with the concept of don't ask, don't tell, it prevented soldiers from, it prevented like senior officers from investigating soldiers' sexual orientations without credible evidence. And what did that mean? That means if you were a closeted homosexual, you were safe. But if anyone saw anything, so if they saw you involved with another soldier of the same sex or heard you talk about it, then they could go to their superiors and then you could be punished for it. And it's estimated that since World War II, 100,000 people have been kicked out of the army for being homosexual. But when this was put in place by President Clinton, it created a safeguard in that kind of, this is the best we can do with a two-party system idea. Now, 13,000 individuals were discharged under Don't Ask, Don't Tell, and they were given something called other than honorable discharge. They were given a dishonorable discharge. They were kicked out of the army or kicked out of the military service, which means they were unable to access VA services, disability benefits, unable to access college programs for veterans, unable to receive home loans for veterans, unable to call themselves veterans, right? Now, keep in mind, 15% of LGBT veterans attempt suicide versus 1% in the entire veteran population. Now, you've probably been at home and you've probably either seen like a Facebook picture or an Instagram picture, a commercial talking about veteran suicide. Now imagine if you saw 15 times more, right? That is the severity that it is in this population. So the fact that you would be restricting them from receiving health care is ridiculous. All right. Now, next step is restoring veteran status and benefits, right? This is the amends. Thank you. So, September 20th, 2011, Don't Ask, Don't Tell is repealed. Those discharged under that can now have their cases reviewed and receive benefits, right? Because it's repealed. Don't ask, don't tell is no longer the law of the land. So they can go to their tribunal and say, I was improperly discharged. Please restore my benefits. Super arduous task, and it's still up to that tribunal to determine whatever they want, right? Fast forward 10 years. This is this September. The White House announces that the VA will proactively review all those cases of other than honorable discharges, and they will proactively restore veteran status, which means they're not going to, go out. They're not going to wait for you to come to them. They're going to actively go back, look what happened, and determine whether or not it was justified. And then they're going to fix it, right? That is amends. You look at what you did or look at what your predecessors did, and then you find a way to fix it. Now, obviously, I got to toot my own horn with the last 5 minutes we have. This is a project that we put together for helping individuals with limited English proficiency. So here's Boston, split out by population fraction, which is Hispanic or Latin. The more blue, the more Hispanic or Latin that it is. Now, here's median income. Obviously, the more red, less socioeconomically well off this area is. And you'll probably start to looking at a certain number of spots that are looking very blue in the last one and looking really red here. Percentage of individuals living in overcrowded conditions. More than one person per room. So you have a lot of socioeconomically disadvantaged people who correspond with Latinx origins and are living in close quarters. You know what this would be terrible for? Terrible for COVID, right? So this is a map of the patients admitted to Mass General Hospital during that first COVID outbreak when things were going wild in Chelsea. Now, at our peak, 1 in 3 patients in our intensive care units were Hispanic or Latin. 1 in 4 of our Hispanic or Latin patients had limited English proficiencies. Almost all of these patients passed through our MGH Chelsea Healthcare Center before they came to the hospital. What we did is during COVID, we turned all of our outpatient health centers into COVID testing sites. And we told people, if you think you have COVID, do not come to the emergency room because, we still get gunshot wounds. We still get broken legs. We still get people impaled by trees. Instead, go to one of these community centers. We will have doctors there who will test you for COVID, who will look at your symptoms and get you a chest X-ray. And if it looks like you have COVID, they will then send you to the emergency room to admit you. So if you are severe, we'll take care of you, but we'll triage and try to put patients who are either don't have COVID or are doing relatively well at the time, send them home for close follow-up. Now, the idea being, if you're a person that doesn't have COVID, we don't want you in our emergency room where you will then catch COVID. Now, language discordant interactions, right? This is when your provider and patient speak different languages. It leads to increased demands for interpreters, and it leads to decreased workflow, right? Because you need more interpreters to answer those questions, but at the same time, you have to wait for those interpreters to come, or you have to dial them, right? This is how we get interpreters for patients right now. We have an old-timey 1970s telephone system where I get one handle, you get the other handle, and there's a person on the line who can interpret for us. Or we have these old conference room phones that are bolted onto little wheels, and we wheel them around. We have to plug it into a wall. But if I want to give you a chest X-ray, I don't really need to interpret all that much complicated information, right? If I want to get a chest X-ray for a patient, I just need to tell you to take a deep breath in and hold it. I need to say like, oh, you can breathe again normally. I need to tell you to just like turn to the side so I can take another picture. So we created this tool called Rad Translate. It's free to use, just radtranslate.com. If you use it for more than 2 minutes, you'll figure out exactly the tricks we use to create this thing. Essentially, it just takes predefined scripts that our staff typically say, and then it's just available in a bunch of different languages. So if I'm a person performing chest x-rays, I can just hit the button to take a deep breath in and hold it. Patient takes the breath, take my picture. That's a higher quality picture for the radiologist to then read to see if there is any evidence of COVID. Similarly, we're expanding this out to other departments, other procedures, other groups. This is not something that is rocket science. This is really easy, really low-hanging fruit, just the ability to communicate with patients effectively when there's no interpreters available at 2 a.m. or when you're swamped and all of your Spanish interpreters are seeing patients, you can still get to work. And so we did some testing and we showed that it reduced care delays. Technologists felt it made their jobs easier, and it was an effective addition to their workflow. So what can you do, right? This is allyship. It comes down to sympathy versus empathy. Sympathy is our natural reaction. Sympathy is born from pity and aversion to pain. Sympathy is looking at yourself, your perspective, your experience, and trying to fix the world around you so you don't have to feel pain or you don't have to see pain. And it's motivated to fix things for people. Empathy is a shared emotional connection. It's a learned response. It requires understanding their perspective, and those with empathy are encouraged to fix problems for someone else, fix problems with someone. Now, here is this Beverly Hills 90210. This is the new one. What I love about this is they had some strong sympathy here and wanted to be politically correct, so they added a black guy, and it looks super awkward, right? Sympathy leads to these situations where we really put our foot in it. Really leads to tokenism, over-reliance on perceived successes while ignoring underlying systemic issues. And an example here of tokenism is when you have like a single woman on the board of your company and you say, hey, we have a woman here where women work here, right? But if you have one woman and the rest of your culture is toxic for women, right? That's not progress. That's not success. What you need to be doing is looking at these issues, acknowledging them, working on changing that culture, and not claiming victory before you've even begun to think about your issues. Now, it's 11:16. I can always go on for hours about this, but I won't because you have questions. But what I will say is I'll jump here and I'll close with this, right? Martin Luther King. I personally don't like to quote Martin Luther King because I think he's wildly overquoted, and it allows people to kind of blow his message way out of proportion when he was much more radical than people give him credit for these days. He was similarly as radical as Malcolm X, but people now have kind of turned him into this tool that they can actually use to kind of account for tone policing and all sorts of stifling of Black voices. But Martin Luther King as a man was a great man. So of all the forms of inequity, injustice in healthcare is the most shocking and inhumane. Yes, so with that, cheers.
Awesome. Thank you, Dan. So we do have a couple of questions coming through. We'll start here. Does Rad Translate account for the many different varieties of Spanish spoken around the world?
It does not. Could it? It certainly could. So we created Rad Translate out of an emergent need. And now this is where you guys come in, right? You lovely individuals at the Broad with your infinite big brains and your endless uh, endless science near you, right? We created something out of a need which could only go so far. Things like funding, things like finding ways to take it to the next level, expanding its language base. That's something that needs to happen. The problem is in our clinical world, things like finding the funding for that, finding the manpower for that, finding the technical expertise for that can be challenging. And a lot of people ask me, how do I get involved in health equity things? Or like, I'm a white guy, what could I possibly do? This is a thing that you can do. What you need to be doing is taking your skills. Maybe you're a great computer programmer. Program some stuff that's helpful for health equity, right? Maybe that's something like, well, we can talk about the different programs that are out there, but maybe you're really good at filing paperwork. File paperwork for health equity. There's so many opportunities, right? You just need to find a person who can help drive you in that way. And if you're interested, send me an email. I will put you right on that.
Great. Are there any instances of something similar happening for transgender women and breast cancer of any race or ethnicity that you're aware of?
Super interesting topic, actually. There's a lot of researchers looking into that. Actually, a good friend of mine who's now at Mayo in Florida was really interested, and I guess now he's the world expert in it, right? Because he's like the only guy who started asking these questions. But what ends up happening is part of gender conversion therapy, or that's probably not the right term for it. What is it? It's
Gender confirmation.
gender confirmation surgery is top surgery for some individuals. Top surgery involves a mastectomy where you remove the breast tissue. If there is no breast tissue left behind, then you have no risk of breast cancer. That's why some patients with something called a BRCA mutation, which places them at a high risk for cancer, they'll undergo prophylactic mastectomies where they will have the breast tissue removed. Now, the question becomes, how do you know? So what you need to do is you need to get some imaging after gender confirmation surgery to see if there's any breast tissue left. Hey, everybody, it's Dan Chonde again. Sorry to interrupt what is probably you listening to me, but, I really wasn't listening during that last question, and I answered it for trans men when the question was clearly about trans women. So here is what should be the correct answer to that question. And yes, I do wear the same clothes pretty much every day. So my outfit is always the same. This is an entirely different day. Let's jump onto some slides because I love slides. All right. So with regards to breast cancer screening, right? In general, anyone with breast tissue is at risk for breast cancer. So we see breast cancer in cisgendered men with gynecomastia, which means men with breast tissue, like we see breast cancer in women, although at different rates. Now, we do know that breast cancer risk scales with exposure to estrogen. And so obviously, breast cancer is a very terrible disease with significant mortality and morbidity, which means reductions in quality of life as a result of a disease. So we have screening tests. Now, for a screening test to be something effective or something that gets used, it needs to fit a number of criteria. It needs to be sensitive, which means just good at detecting the disease. It needs to be relatively cost effective or cheap compared to a disease prevalence. So if you have a disease that almost never exists, it's not useful to screen for it. Or if you have a disease which you can screen for, but it's incredibly expensive, then there's no way to actually scan or test many asymptomatic people. So a screening test is typically given to people who don't have symptoms. Otherwise, it's a diagnostic test. Now, also, these tests need to be easy to implement. In the case of breast cancer screening, that's just a mammogram. You can do it with a special type of Xray machine. So they're very, very prevalent. And then it needs to lead to an improved outcome. And of course, as we all know, breast cancer imaging or breast cancer screening leads to increased rates of detection, which leads to reduction in morbidity and mortality from breast cancer. Now, with regards to breast imaging, part of the challenge of screening tests is that there's many different groups that offer their opinions on how we should do this any type of screening test. Here are 6 different organizations, all which care for cisgendered women, all with different recommendations on when to stop, when to start, and how frequently women should be undergoing breast cancer screening with mammography. So this is all based off of different studies, which is a challenge with screening, right? You always base it off of the available information. Now, with transgender women, we don't have a lot of population level information. So we don't necessarily know the true risk and prevalence of breast cancer in this population. However, we do know that it is, like I said before, dependent on estrogen exposure. So patients who are undergoing estrogen therapy or hormone therapy are at increased risk. Similarly, estrogen drives breast growth. So these women tend to have denser breasts. And if you are a woman and you've had a mammogram, perhaps you've heard a mammographer tell you that you have dense breasts. That just means it's hard for us to see through the breast on X-ray, which can limit our sensitivity for cancer. So those patients with dense breasts are at an increased risk relative to the general population because our screening test is less sensitive, less able to pick it up. Similarly, if any of these patients had a history of chest radiation, they're at increased risk for breast cancer, and then a personal family history of breast or ovarian cancer. You might have heard of genetic breast cancer, BRCA1 or BRCA2 cancer. So these are patients who would be at increased risk if they were to develop breast tissue. Men with BRCA1 mutations who go on to develop gynecomastia are at an increased risk for breast cancer. Just like a transgender woman who begins hormone therapy and develops breast tissue would be at an increased risk for breast cancer relative to a transgender woman who didn't have a genetic history of a BRCA mutation, similar to a cisgender woman who has a family history of BRCA mutation and has breast tissue. This is the reason some women undergo prophylactic mastectomies or removal of breast tissue just based on their history. Now, as I had said on the previous slide, there's a number of different organizations. The organization that I belong to is the American College of Radiology. We are a group of radiologists who are driven by radiology-based research and population studies. And our recommendation is, out of an abundance of caution, that any patient who has a hormone exposure of greater than 5 years should undergo breast cancer screening. So this would include transgender women over the age of 40 or within 5 to 10 years of having a 5-year exposure to hormone therapy. So you have to be on hormone therapy for at least 5 years. Then we would recommend breast cancer screening. And similarly, we do leave space on a case-by-case basis. So that is probably way more information than you wanted, but I think this is interesting. And, you know, the more you know. Great. Now back to the talk.
Thank you. Do you think that a vaccine passport system, i.e., the one in New York City, is inherently discriminatory to Black Americans who have centuries of justified distrust towards the healthcare industry?
You know what? Kim Janey got a lot of crap when she answered that question, but Kim Janey was not wrong. You know, I am fully vaccinated. I was first in line for a vaccine because honestly, worst comes to worst, it turns me into a government robot. At least I can take a break. But in truth, it's ridiculous that we would go to these communities, which we have systematically marginalized for generations, and then require them to engage in our healthcare system. We weren't thinking about them before. Why would they think we have their best interests at heart now? You know, I think that a vaccine passport it's offensive. That's not like the politically correct answer. The politically correct answer is to have no opinion, or to throw it to someone else. But, you know, I think if we want to make changes, what we need to do is go out into the communities and we need to get their trust. And then we need to start vaccinating individuals who are willing to get vaccinated. That's the one thing that we hate to do, even in hospitals, right? We hate to go into the community and engage with the community. We want them to come to us. We want them to come give us their money and then go home, and we'll take our money back to the suburbs. But what we need to do is invest in these communities. And that's what my project, The People's Heart, is all about. It's about investing in the arts of these communities and bringing in their art into our hospital. And through that connection, bringing our hospital into the communities through that art.
Thank you. We had a question about the terminology that you used around American Indian and Native American. The question is, I know the terminology of American Indian and Native American has been controversial. Is the usage you used generally accepted in all fields now, or are there still differing uses?
That's a tough one. I think what you need to do is first we need to consider that most fields don't have any guidance on this, right? If I'm writing a paper for the Journal of the American Medical Association, they're not going to know, right? Unless they probably don't have a American Indian terminology expert. So what you find is, what I like to do is I like to hear from sources. So I will go listen to different talks from individuals, or, you know, you can find a lot of lectures these days on YouTube from medical conferences, from people because of Zoom, which is amazing. Zoom has opened up this opportunity. And that terminology was actually borrowed from a professor in the Midwest. I think it was a professor at South Dakota who runs a indigenous health program. So it's a medical school which has a special pipeline for indigenous students who then, you know, work closely with reservation medicine. I'm going to try to remember his name as I bring this thing up. His name is Donald Ware, W-A-R-N-E. He's a great guy. He's very smart. You can read his papers. You can see him on YouTube.
Thank you. Are there ways to provide folks with limited English with ways to ask questions to their healthcare providers, perhaps with a similar machine translation type paradigm?
Yep. Yes, there are. Yes. Yes. All it requires is someone with a monicum of coding experience and an interest, and you too can create this website that we built on a WordPress engine using some few tricks, which if you look at the problem hard enough, you will come up, or you read the paper, you will see exactly what those tricks were, and then you can make a huge advance, right? I am a physicist by training. I am a MATLAB guy by training. I am not a website coder. So, this was all like a team project on this one. And, I would love to take it to the next step. I'm just always looking for talented people, funding, etc.
Is there evidence that switching to universal healthcare helps to address some of the inequities that had historically been built into the healthcare system?
That's an interesting question. One that I don't know off the top of my head, but I will say a major thing to consider is that, so there's this Boston Globe article. It came out in 2017, and actually, can I get my screen back up here? Look at that, right? Okay. Color lines persist in sickness as in health, right? This is one of those Boston Globe articles. The Boston Globe loves to trash Mass General. But most Black Bostonians don't travel 5 to 10 miles from their neighborhoods to take advantage of Mass General's resources. We just don't have so they don't feel like this is a place for them, and their providers who are ordering their exams, we don't have the kind of disparities we have in schools. The quality is good wherever you go. Now, let me tell you, you can make the screen go away. Let me tell you this allegory, which I will heavily code. A friend of mine had cancer, and they received some concern that their cancer, there wasn't anything else that could be done, right? Which hearing it's the end of the road from your oncologist is a scary thing. Now, what ended up happening is then the person was like, well, one thing we can do is something called a palliative ablation. So we can make you feel better by treating part of the tumor with give it a little zap. We stick a little electrode in it and we burn it. But the guy who was going to burn it was sick, so he couldn't burn it. So then they had to find someone else. So this was at a different healthcare system. So they had to find another healthcare system, and the only healthcare system they thought of was going to Mass General. They come to Mass General, and the guy who would zap it looks at it and says, this isn't palliative ablation. This is surgical. We can just cut this out and it's gone forever, right? So you had this person who was told that there was nothing left to do at another hospital. They come here, and it becomes an easy fix, right? Like, oh, no, we can handle that, right? So there are huge differences in the level of care that we can provide at these different healthcare stations. And to have this perception that everything is equivalent here is just, a fallacy. Now, this is a long roundabout way of getting back to this conversation of universal healthcare. But if you have populations that don't feel at home in our hospitals, then they're not going to come here even if they are free, right? So what we need to do is we need to work on creating spaces that are accepting and inclusive, and that's what we do at the People's Heart, right? And because everyone in the U.S. is or everyone in Massachusetts is insured, then we can start to show our communities of color here in Massachusetts that Mass General is for them. And then from there, we can start to show the world that this is a sustainable model. And then from there, we can convince all of the tiny brains in Washington that they should push for universal health care.
On that note, that's all the questions that we have for now. Dan, thank you so much. We really appreciate your time, especially given the fact that you're clearly at the hospital right now. So thank you very much. It's 11:30 now, so that'll be about a half-hour break between now and our keynote with Joan Reed. You can come back here to hop in on the main stage. Dan, thanks again for your time.